Good. So welcome, everybody. I'm Roberto Lewis-Fernandez. I'm president of the World Association of Cultural Psychiatry, and it's my great pleasure to welcome you all to this webinar and town hall. It's actually a somewhat different format than we've done before, in that this follows this, we call it a town hall in the US, this tradition where the participants are the ones asking the questions and leading the discussion, if you will. The audience is the one raising the main issues. We have usually a short presentation, today being done by Vincenzo Di Nicola, but my job at present is to introduce Riyadh al Aldawi, our moderator, which I will do in a minute. But first, I just wanted to say that this is the work of the Culture and Family Special Interest Group of WACP. And this group has already been active for several months and has done one webinar previously in September on family and culture in the time of globalization, led by Maria Borxa and commented by Fanny Morel, which was very good. And this is our second offering of the SIG, and we hopefully will have more in the future. So now it's my privilege to introduce Dr. Riyadh al Aldawi, who's Associate Professor of Psychiatry at University College in Stockholm, a psychiatrist and a family therapist, and also the co-founder and co-chair of this special interest group. Riyadh, please carry on from here.
Thank you very much, Roberto, and welcome for everybody for this our second webinar. And I'm very happy that so many of you would like to share with us this webinar. Thank you very much. And actually, I have some information before we are starting, before I'm introducing the speaker for this webinar, my colleague and the co-chair for the Family and Culture Interest Group, Professor Vincenzo Di Nicola. I would like just only to inform you that the time for this webinar will be 1.5 hours. So this webinar will be recorded, and this is important as a documentation. And the form, as Professor Roberto told you, it is a town hall. That means that we would like to invite all the participants to share your things and thoughts and your clinical experiences on the topics we are rising up this evening. I would like to say that the town hall will be in two forms. One is that you can use the Q&A, put your questions, and we as a panelist, me and Vincenzo, will look and we will invite, I will invite it as a moderator for this webinar, invited the people put the question on the Q&A. But at the same time, the floor is open for the chat, for all the participants to put their comment or their ideas on the chat. The chat will be open for all the participants. So that's, I would like to mention for all of you. The Q&A will be just only for us as a panelist, but the chat will be open for all. The topic for this webinar, we chose it very interesting, I think. It's on a triangle about culture, family, and psychosis. Without going inside this question, we leave that to my colleague and my dear friend, Professor Vincenzo Di Nicola, who is the co-founder and co-chair of the Family and Culture Interest Group. Vincenzo Di Nicola, I think, is very well known for many of us and all over the world. He is a president of Canadian Association of Social Psychiatry, as well as he is a president-elect for the World Association of Social Psychiatry. And he is a professor at the University of Montreal, as well as a clinical professor at George Washington University, author of many very interesting work on on family. He is a child psychiatrist as well as anthropologist and a culture and social psychiatrist. So I would like to invite my colleague and friend, Professor Vincenzo Di Nicola, which will get his presentation about this topic on culture, family, and psychosis. Please, dear Vincenzo.
Thank you very much. Thank you very much, Hans and Roberto and Riyadh. My name is Vincenzo. I'm speaking to you from Montreal. Let me start my share screen so we can begin our conversation about families, culture, families, and psychosis. So as Roberto said, it's kind of a webinar, but really more like a town hall. So all I want to do this morning or today, for those of you around the world, is to set the stage for the question and take it from there. So this is the save the date poster we sent out. That's a little bit about me, which my dear friend Riyadh just spoke about. I'm also involved in at the Ambrosiana University in Italy. And it's important to state that none of us have conflicts of interest to report, at least on the financial level. Maybe psychosocial conflicts, but not administrative conflicts. Let me take this a moment to remind you that the World Association of Cultural Psychiatry will have our annual Congress, or not annual, but our Congress, World Congress, the 6th World Congress in Rotterdam in the Netherlands in September of this year. So just a word about the Family and Culture Special Interest Group, which Riyadh and I have thought up. We've been talking about this for years, and finally, with Roberto and Hans's help, we've made this a reality. This is our second event. Our mission in this Family and Culture Special Interest Group is to bring together mental health professionals and scholars, sometimes they're not clinicians, in cognate or related fields, who have special interests in the family and culture, how they relate to each other and enrich each other, and how to investigate, study, and promote research, teaching, practices, advocacy, and policymaking to advance the study of the family in the cultural context. And that is the heart of what motivates me to do this work. And I think today I'm going to try to concretize or give you a very specific example of this. Okay. Here we go. So this is a favorite cartoon of mine, arguing that without a family approach, without culture, something's always missing. In other words, by looking at the individual or even a unit of study alone, without understanding meaningful context like family, community, and certainly without understanding culture, there's always going to be something missing, as we see here, the magician who's looking for the other half of his assistant that's been sawn off. So jokes aside, we think it's very, very important to consider these broader contexts. So the question we want to address today with you is, and we just want to put the question, give you a little bit of background, and then have a discussion about it, even a debate. So should the involvement of the person's family in the treatment of psychosis be adapted to their cultural background? And if so, how? Now, we want to stress that this is not a rhetorical question. It's not as if we're asking this question, we know the answer. I don't think anyone really does know the answer, but I think we should investigate it. So we don't take it for granted. What I want to emphasize is that we can best address these kinds of questions as an interface, as an interaction among the variables, among the salient features. So the lived experience of anything, and this is the heart of my beliefs in everything I do as a psychiatrist, a family therapist, and certainly as a social and cultural student, that something like psychosis, but including anxiety, depression, trauma, another area of my specialization, is best understood as taking place at the crossroads of significant social contexts and cultural processes. Now, I think of this as a three-lens problem. The idea of lenses comes from both the family systems approach and a cultural anthropology approach. And again, I believe that lived experience is at the crossroads of these things. What we're looking at today is the crossroads of culture, families, and psychosis. And depending on what we start with, whether we start with culture, whether we start with families or psychosis, or the interaction of any two, it will have they interact with each other. That is the most important message I'd like to share with you. Now, a very brief history of the salient points in the study of schizophrenia and its allied in psychiatry and then allied fields. Angela Woods, who's a renowned historian of medicine and psychiatry from England, calls schizophrenia the sublime object of psychiatry that at the beginning of the classification era was defined, criteria were given, it was, there were more and more refinements in terms of what it meant, including the implications for therapy and treatment, which led, and it sounded like we were getting something solid underway. Every generation has questioned not only the definition, but the criteria and so on, in what people would try to defend as an evidence-based way. But I think it's a little bit more complicated than just the evidence, because the question is, who decides what the evidence is, what's salient, and so on. Then there was another area I call the social context era, and I'll speak to that in a minute in more detail. And then finally, the family therapy era, which blends into the cultural era. So here's the cover of the book by Angela Wood, The Sublime Object of Psychiatry, Schizophrenia in Clinical and Cultural Theory. So if you want to look at these three lenses from the point of view of psychosis, but from a very well-informed historian, that's a lovely book. This is the cover of Mara Silvini Palazzoli and her team's famous book on family games, which was both very bold and got her into a lot of trouble as soon as especially United States, the movement came along to try to have patients and their families as partners, as opposed to having them feeling blamed. But that's a small historical detail. So in the social context era, it's very important to know that very soon after psychiatrists, as specialists in psychosis and schizophrenia, define the term and try to outline the criteria. So we have already early on in the 40s, a sociologist in the United States called Norman Cameron, who wrote two brilliant papers in two different versions, 1943, 1959, on the paranoid pseudo-community. In other words, going beyond just the definition of what paranoia is as part of psychosis and looking at what is the actual social function of that. Well worth looking at. And then we get immediately into someone that's had an outsized influence on both psychiatry. This is a cultural anthropologist, Gregory Bateson, who is brilliant in his field as an anthropologist, is considered one of the founding fathers of family therapy, certainly the mentor to all family therapists, and had a significant impact as well on psychiatry with his double blind hypothesis, which many people in a supercilious way just dismiss. This was a brilliant team of researchers at the MRI in Stanford and Palo Alto, and they weren't silly. It's worth rereading those papers and considering how serious this hypothesis was when we didn't have much better going on. The psychiatrist R.D. Lang kind of tilted against the medical model. He was a psychiatrist, classically trained, and he saw schizophrenia from the point of view of the subjective experience of the person suffering with what he called ontological insecurity. And he coined such terms as mystification and invalidation as the person's experience in their own families, which he later came to call the politics of the family. Silvano Arietti was another psychiatrist, psychoanalyst from Italy, later had a distinguished career in the United States, and wrote a very well-known book at the time, 1975, The Interpretation of Schizophrenia, which won no less than the Pulitzer Prize in the United States. It was extremely well written. And he effectively tried to show that there was a biopsychosocial model when few people were talking yet about that. So I would call that the social era. Now, let's look at the interaction of families and psychosis. And I'm going to give you only one example of what that might look like from someone I trained with, Mara Silvini Palazzoli in Milan. And I did an interview with her, which I published, which is called The Roadmap to Schizoland. So that's how she was looking at how she understood these families. It's very interesting to look at the title of her first book that made her famous, Paradox and Counter-Paradox, a new model in the therapy of the family in schizophrenic transactions. So rather than looking at the individual as the schizophrenic, as the psychotic person, she said it was the family that was in the schizophrenic transaction. This already sets the stage very, very differently. And she talked, of course, about counter-paradoxical interventions that would kind of blow up the assumptions and allow the people to be more, the person in question that's suffering or the family that's suffering to be more free, to be more comfortable, and to answer more comfortable function, let's say. Her next book was Controversial Family Games. It was not the next book, but the next book on psychosis, Family Games, General Models of Psychotic Processes in the Family. And she did something very bold. She tried to come up with a universal prescription that would work for everybody. Again, this book was criticized because it was just the dawn of the era of really highlighting the need to respect people's experiences and so on. And it was seen sort of counter to that trend. But I mean, there were some very brilliant insights nonetheless there. Now, if we look at this question from the point of view of the interaction of culture and psychosis, again, there's many things to say. I would like to concentrate on one of them because it was both based on brilliant observations, very interesting empirical research with many adaptations, including by family therapists. So George Brown was another sociologist that was absolutely brilliant in bringing forward a number of important observations in the psychiatric clinic or on psychiatric questions. And he noticed something very interesting. This is salient here. He noticed that the people that was discharged from hospitals with the diagnosis of schizophrenia that went to lodgings, the English term for, going to a residence or a place to live, as opposed to their families, did better than when they were discharged to their own families. And so they started doing research on this without any more of a hypothesis or a theory than that. And they started just examining what people reported in these different environments and looking at family environments of these people that were discharged from hospital, going back to their families. They studied 5 components, 3 of which have become very famous. The 5 components are critical comments. In other words, you're schizophrenic, you've had a psychotic episode, you get better, you're discharged from the hospital, you go back to your family, and you're exposed to critical comments. You're exposed to hostility, and they studied what they called emotional over-involvement, what Salvador Minuchin called enmeshment. And then there was these 2 more positive things that he called warmth and positive regard, which in these families were lacking, while the 3 negative things, critical comments, hostility, emotional over-involvement, were present, and that they predicted were the stressors, the triggers that would lead to relapse at a higher rate than people going to lodgings or non-family environments. Now, this literally created an industry of research. So if you look up, you'll see reviews of expressed emotion in everything from cultural anthropology to social psychiatry to family therapy, mainstream psychiatry, general psychiatry, research in schizophrenia, like in the Schizophrenia Bulletin. So it was a veritable industry or cottage industry of research that looked very promising. I once called, and I trained in that department, and I know all these people, and I called it a kind of an empirical model in search of a theory. They never really elaborated a theory. They just talked about these salient components. My cultural critique of this is that it's very interesting. And when they try to import or export this to other cultures, what they did is what I would call comparative psychiatry. In other words, does EE function in North India? This is a series of studies that I criticized. And I think that's an okay question to ask. I mean, can we observe this? Can we see this? Can we measure it in another context? Asia, Africa, India, South America, no matter where. That's not really a cultural question. That's a comparative psychiatry question, as my mentor at McGill, Henry Murphy, would say. It's not truly cultural. It's not really an anthropological or cultural psychiatry question, or even a social psychiatry question. What it is an attempt to export ideas from the West or the North to other parts of the world. A truly cultural approach would study the same processes in that, sort of theory-free in that culture, and see what are the salient indices, aspects, observations that will bubble up that could be observed in that environment. That's my cultural critique. Now, having said that, my main argument is this. If the question is about how can we help people that are suffering with these kinds of difficult experiences, many of us are committed to family work. I think all of us here present would be committed to a cultural look. So if you're looking at psychosis, to what extent is the family's involvement change based on their culture of origin or the culture to which they're trying to adapt, and in what ways does that? So I've just highlighted some of the ways in which that could be salient. I'll stop there, And I'll say this is my favorite thing, positive thing to say about the family from a British historian at Cambridge called Zeldin, An Intimate History of Humanity. He said, I see humanity as a family that is hardly met. I think that's true both at a kind of small level in a given family, but the whole world too. So I will stop there. I want to thank the people that are involved with this with me here, Roberto, Riyadh, and Hans. And I want to remind you again that our World Congress is coming up in September in Rotterdam. Thank you very much. I'll stop there and give it over now to Riyadh, who will animate the discussion, the town hall meeting.
I'm sorry, Riyadh, you're muted.
Thank you very much. Thank you very much, Vincenzo. Sorry for that. Thank you, because your presentation really raised up a lot of interesting question in historical way and in clinical way. So let us open the town hall for all participants who wanted to ask or to comment the question and the ideas Vincenzo recently raised up. If there is any participant would like to start by directly question or comment, or just only I don't have in the Q&A any questions to Vincenzo, so maybe anybody would like to say something.
So sorry, Riyadh, there is a question actually.
No, it was about the audience.
No, there is a question from Hazel Gabriel.
Yes, você do parlicar?
I gave Hazel Dabreo the opportunity to ask her question live.
Yes, please.
Hazel?
Yes, hello. Thank you for the opportunity. I am a Caribbean Canadian psychotherapist teaching psychology at the moment. My question is, do you have a comment on psychosis as a sort of normal manifestation of chronic child sexual abuse, particularly in the case of incest? We see a lot of it in the Caribbean and Latin American area, where psychosis is as overdiagnosed in children as ADHD. And from my practice, I am seeing more and more linkages between its manifestation and incest. Do you have a comment?
Sure. Well, I am, as Riyadh said, I am a child psychiatrist, so I do see children. I think there's many sub-questions in your comment. First of all, let me start with the idea of how to understand the nature of psychosis. I mean, schizophrenia would be a very specific example or type of psychosis. There are many types. If we can eliminate the psychoses that are induced by substances, which is by far the most important, the most common thing we see in kids in a place like Canada, at least that we recognize. Let's eliminate that and refer to the things that are from stress, environment, and so on. So all of the people that I cited after the founding what I call the classification era, starting with Kraepelin, Bloiler, who named schizophrenia, and then Jaspers, Schneider, and so on. After that era, almost everybody immediately questioned first whether the medical model is the right approach. Is it a disease? I mean, R.D. Laing said there's an epistemological paradox, and this is actually relevant to your question. There's an epistemological paradox in talking about schizophrenia because you use basically a philosophical or phenomenological approach to its understanding, because there weren't markers and other ways to say this is a disease of the brain. But on the other hand, after the 50s and the psychopharmacology era, the mainline treatment besides hospitalization was medications. So I said there was a fundamental paradox there. Let's put that aside. That's very important. So immediately people questioned the medical model, and then there was a whole series of things. So sociologists said, Well, let's look at the social context. Is there a sense to which people construct their lives or experiences around certain things? So, for example, R.D. Laing, who was a classically trained doctor, psychiatrist, and also classically trained psychoanalyst, absolutely orthodox, as he himself insisted. He started saying, maybe we've got this wrong. He never said, and I know him personally, he never said I'm an anti-psychiatrist or that schizophrenia doesn't exist. He just said these are adaptations, these are normal adaptations to an abnormal world. So that's one way to answer your question. Another way to, I think, maybe closer to what you're getting at, besides historically, is in many ways we're questioning what is the sense of psychosis. I mean, what happens when you confuse a child's experience that's been abused with psychosis? What are the implications? What if we call that ADHD instead of psychosis? What if we call it this thing or that thing? And I think the stakes are very important, above all, because today more than ever, we value the person's experience, their personal construction, their subjective world matters as much as anything else. So just this week, I had a child that's continually, brought up to the CAS, including by me, because he says, my mother hits me, my parents hit me. And then when you go investigate, I said, well, we've heard this many, many times. And my answer is, well, where there's smoke, there's fire. I don't know what the historical, journalistic truth is, but I know that the child's reality is he feels abused. So again, it's R.D. Laing's dictum, it's a normal adaptation or an understandable adaptation to an abnormal or an unreasonable provocation. So, I mean, I'm absolutely with you. I agree with that. That said, we can't throw the baby out with the bathwater. Some things are incontrovertibly difficult to live through, even if you want to see them as opening other worlds, other, experiences. We know that there are positive parts about being manic, or at least mildly manic. Most people are incredibly productive and creative have at least a little bit of a streak of mania. So we know that there is an adaptive part of all these experiences. The last thing I want to say is there is a whole community of people now, like the Hearing Voices community, that say, well, I hear voices, but I'm functional. Yeah, I'm a lawyer, I'm an engineer, I'm a bus driver, doesn't matter what, a homemaker. And no, that's my reality. I don't particularly feel the need to soothe it, certainly in the standard way. So all these voices, if I can use that as a metaphor, should be heard, and all these perspectives need to be integrated without forgetting that sometimes, maybe often, it represents real suffering.
I would like to rise up again to Dr. Hazel. Could you explain to me, please, what you mean by abusing the child, by put the diagnosis psychosis for the child? Did I understand your question?
Yes. For example, take a boy child who is being sexually abused by his mom. He's 11 years old and just has no language to explain to anybody what's going on. So he just takes a habit of throwing himself off his chair at school.
So mom used that and presented this problem if the child talking about her abuse. So she chose to present him as a psychosis?
No, he himself began to behave in a very weird way. He wanted to bring attention to himself so that somebody could ask enough questions to force a truth out of him. He didn't know how to do that on his own. So he deliberately acted in ways that were outrageous, throwing himself down and talking in strange ways. And everybody did take him seriously and took him for MRIs and brought him to other countries for more prolonged medical investigation. And all along, it was a child inside saying, please, somebody, get to the truth. And he just never knew how to say it himself. But he was diagnosed with psychosis and he was treated with antipsychotic medication.
But Dr. Hazel, how they treat him? Did they, the symptoms he rising up, is that psychosis with hallucination, delusions, and things are?
So you're wondering if he met the DSM criteria, delusions,
Or if
disorganized
the doctors,
speech, and
but how the
hallucination.
doctors mentioned that he is a psychosis?
Yes, but remember, I'm speaking from the Caribbean context now, and we do not have a very sophisticated system for diagnosing or for even interviewing. So anything that looks loud and uncontrolled risks a diagnosis of psychosis, particularly in a child. You don't know what to do. They don't know what to do with this sort of crazy, erratic behavior. So they label it something that they can medicate.
Well, that was exactly R.D. Laing's point, and many other people. That is the family therapy perspective, in that people, whether they do it consciously, willingly, or even genuine psychosis, can be
Right.
best understood in its context. In
There
other words,
is some comment from Dr. Paralikar. Please, doctor.
Yes, can you hear me?
Yes, please.
This is very interesting because we can see it through different lenses. And hysterical psychosis was the term used before the diagnosis became more delineated, defined, and sharper, that it was a means to express the inner conflict. And that is
Dr.
why
Parlikar, could you present yourself, please, because we don't know your background?
Sure. I am a psychiatrist from Pune, India, with
Welcome.
work in cultural epidemiology. And I am about 65, if that is a part of my introduction, so that you will understand how I am conversant
Good.
with
Thank
the
you very
older
much. Please continue. Yes.
I was just going to say that
Yes.
Vasudev is the chair of the Culture and Sexuality Special Interest Group of WACP. I just
Oh,
wanted to
welcome. Okay.
bring
Sorry
that
that I
up.
didn't
Thanks.
know about that.
That's okay.
Thanks. So that is another option where another perspective, I would say, where it arose out of incest, and the child was trying hard to get it out into the open,
Yeah.
so that the experience, the lived experience, improves. Whereas the medical model looks at it only through their lens and keeps on treating by investigating and giving medicines. Whereas the making sense of psychosis is very important, in which rather than restricting to the diagnostic categories, it would be important to understand the meanings and the perspectives of other people from the family. So it's a very interesting comment, question, and webinar that we are having. Thank you.
Thank you. Thank you very much. Thank you. There is a very interesting question rising up by colleagues Maria Mancini. Please, Dr.
actually, before we go on to Mary Mancini,
Do you have a comment?
Yeah, I'd like to make a comment because I think that Hazel's question is a critical one, and I'm not sure. There's so many layers to it. It's a very complex question, because one of the layers she's adding about sexual abuse is that, you know, sexual abuse always brings the possibility, if not the probability, of trauma. So trauma would be another lens, you see. So it would be like we could do the same exercise, you know, culture, families, and trauma. You know, which is I do a lot. I work a lot in the area of trauma. So at what point, I think one of her sub questions is, at what point does trauma mimic or provoke or look like, you know, psychosis? And I think this is a very difficult question. I want to share a very quick anecdote. The biggest clinical mistake I made in my life.
Please short, Vincenzo, because there are many questions. Yes.
Yeah, the biggest clinical mistake I made in my life was treating a 9-year-old girl. And I'm not an idiot. I mean, she had delusions, everything. So as if she was psychotic. I mean, it wasn't me that did the diagnosis, but I inherited her after hospitalization. And based on what was reported and what she said, it was congruent. It was consistent. So long story short, I'm treating her like she's psychotic, very low amount of medications. Then I tapered off the medications and just followed her. Many years later, it was discovered that her father had been sexually abusing her. So when she would say in the middle of the night, I hear a voice in my ear,
Exactly.
She was sleeping on a bunk bed, so that literally when an adult was standing, he would be speaking into her ear and abusing her at night. Now, I felt terrible.
Yeah.
Now, after having tapered off the medication, I did all the things I would have done if I would have known the whole truth anyway. But I did feel very terrible because it brings us to the fundamental question: do we just buy the diagnosis, or do we have a higher responsibility to question even symptoms and make sure that there isn't a better explanation? So I really hear your question, Hazel. It's a difficult one to be sure of. And it's just a reminder for me as a clinician to think about other possibilities all the time.
Thank you, Vincenzo. I would like just only to say that the question of incest is very, very complicated because it is in different way, treats in different way in the part of the world, in cultural way and in a religious way. So we have maybe to discuss that as Vincenzo recommended, really. Thank you, Mr. There is a question from, a very interesting question. Could you please, Dr. Mancini?
I'm not a doctor, I'm myself. I am connecting from the UK, from England.
You are very welcome. Sorry, yes,
hello.
please. You can present yourself where you are
yes,
working
I'm a
your comment.
I suffered with psychosis in 2006, and now I take medication, and I take part in research, medical research. One of them is about open dialogue, and I'm quite impressed by this new method of curing. So I want curing of. The open dialogue involve people, family, people who suffer psychosis and family to join, to meet together and talk about, find a plan, a proper plan for the person suffering with mental health. So I have a plan, a cure plan. So I was wondering, what do you think about this method of this new method, and if you would apply to as a method for involve the family and the friends in people suffering with psychosis.
Vincenzo, do you have any comment for that?
I don't know enough about that particular approach, but I do.
Not me as well. So
It's from Finland and it's expanding now in Europe.
Right, right. No, I've heard of similar approaches all around the world. My general comment is this: that the more we listen to people's subjective experience, how they define themselves, what they're lived. I like this expression, that we say in French, vécu, the lived experience. I think the closer we get to building partnerships with people, and the more we do that, the less likely we are to misunderstand the nature of the experience. So we're less likely to label it as psychosis when it's, incest. If we can create an environment, which is, I think, one of Arthur Kleinman, who's a cultural psychiatrist and anthropologist, says, we get the truth if we go closer to the person's real world, in their kitchen, in their community, and so on. If we can create an environment that's propitious for people to feel comfortable to tell the truth, we'll make fewer mistakes, and we'll have better capacity to honor their experience and not distort it, through a medical model or any model, but really let's stay very close to experience. If that's what open dialogue means, I'm all for it.
No, thank you.
There is a question from colleague Paralika.
No, Michelle Garcia.
Where is Michelle Garcia? I don't find her question here.
She will ask the question live.
Live, right.
Okay, please, Michelle. Michelle Garcia.
Yeah.
Hi, can you guys hear me?
Yes, please. You're welcome.
Lovely. Thank you for
unfortunately, your questions disappeared in my screen.
Oh,
that's why.
No worries. I can read it out loud. So hello, everyone.
You are very welcome.
I'm calling in from New York. Thank you so much for providing context about the history of individuals in recovery, having better recovery outcomes in hospital or treatment settings, as opposed to with the family, due to those 5 areas of critical comments, hostility, emotional over-involvement, etc. So of course, now there is a movement towards more community-based treatment and family involvement in recovery. And I'm actually involved in this incredible new initiative across New York State, which supports individuals recovering, in their transition back to the community from any treatment setting, with whole family involvement and support of their families. And we're aiming to reduce rehospitalizations, unnecessary ER visits, all while supporting whole family health. So those findings that you shared about, Julian Leff's 5 components that hinder successful family support is really insightful. So on the flip side of that, I'm wondering, do you have any other studies or best practices to share about how families can better support their family members in recovery?
Actually, we are okay. Vincenzo, please.
Yeah, let me just begin this conversation. What I offered is not an exhaustive list of what's going on today. I wanted to give a few canonical, key examples of some family work and some culture work. Now, first, a quick comment. A lot of people from a very limited point of view, even if they're scholars, okay, for example, a researcher in schizophrenia was, those family people were crazy. Look what Frida from Reichman did at Chestnut Lodge. She talked about refrigerator mothers and mothers driving children crazy. This is not, I read those papers, okay? This is not what they wrote. This is not what they meant. And this is not what they're talking about. Here's my overall comment. There's a lot of people say, especially the biological people, I see the family folks, the cultural folks, they get it all wrong. It's really in the brain. There's very little data compared to family and cultural data. The biological data is very limited. I have mainstream training. I trained with all these people. I knew Seymour Ketty and all these people. But these are not true. So
we have to.
I understand. Let me just wrap up. It's wrong when people take one perspective. So here's the bottom line. A lot of people think that you have to be very positive, like my friend Maurizio Andolfi is a famous family therapist. Look at family resources. Sure. But the people that were looking at these negative things, including Frida from Reichman, including the expressed emotion stuff, meant that it's not black and white. It's not all or nothing. Families love their family members, and sometimes they're frustrated and they drive each other crazy. That's part of the truth. So we can't. I can't give you a quick answer as to all the interesting data available on what are called PAC teams supporting families in the community. But the research is very strong that if you're working, and especially in what's called first episode psychosis, if you help the families adapt better, with psychoeducation, understanding, there is better outcome. But it points to the fact that families are both resourceful and limited. That's my overall conclusion.
Good. I have a hand rising up by Angeli Joseph. Please,
Yes.
Doctor.
Yes, thank you very much. I'm Angeli. I'm a marriage and family therapist in the Ottawa, Canada area. Culture and family have been an interest of mine for a while in my practice. I'm really liking this topic, and I think I entirely agree with you, Vincenzo, that there is no black and white answer about whether to involve family or not. Especially because I guess in some instances in my practice where perhaps I might see someone after they've left the hospital, because I work in private practice, some instances there might be occasions in which their psychosis might have resulted from dynamic shifting in their family, because family members there are discoveries that have been come to bear in the family system, or children have grown up to realize perhaps their own historical experiences in the family, and they're looking for a space to be able to process all of that and to be able to return to their family, or wondering what to do in their family context. I've often found that those members those patients have often benefited greatly by finding other community outside of their family in order to heal, to be able to make a secondary family in the community of understanding of what's happened. I also think that things in North America, I think there are aspects in North America that also make psychosis a less pathologizing experience that are outside of our field. Things like talk shows, believe it or not, Dr. Phil, or things like people that that actually expose the quote unquote bizarre or strange or weird to us in a way that might help to expose and bring more familiarity to those experiences. I'm reminded of a time soon after my own graduate studies. I had an exceptional opportunity to go to India and be an intern in a mission hospital. And there I was in the psychiatric ward. I was really curious about how psychiatry functioned and our mental health services were delivered in India. And it was fascinating that the psychiatrist always asked the patient for their consent to bring somebody into the therapy session with them, either a family member or a friend who could be an advocate or just another person with them if the patient required. The other interesting thing I saw was that the door was open. This was something that would be unthinkable in a North American context, but the door was open to the waiting room, and there in the waiting room were lines and lines and lines of people, and they were all witnesses to the therapy session. I thought what an amazing way to bring and normalize our experiences, our human experiences, our family experiences by educating those in the waiting room of the things that are happening inside our sessions.
Exactly.
I just want to say that. Thanks.
Thank you very much. Very, very nice comment from the practical way. Thank you. And I think we have some questions here. Dr. Paralikar, again, would like to share something.
Thank you, sir. I was wondering if trauma, dissociation, and psychosis could be considered on the same spectrum of psychopathology. Of course, they might have branches going in other directions of psychopathology, but this remains a prominent possible fallout of trauma.
I think it could be, isn't it, Vincenzo?
Oh, I think that's very.
I think it could be.
We happen to have an expert here, Roberto.
Roberto is an expert. Maybe Roberto, you could share with this question. Is very interesting.
Okay. Thank you for calling on me.
This is your subject.
Yeah. No, the field is still struggling, I should say, with this question of where is the line between dissociation and psychosis, which are both connected to trauma. There's a fair amount of information on the role of traumatic experience in the precipitation of forms of psychosis. And both positive and negative symptoms have been associated with traumatic experiences earlier than in life, usually. And there's a strong connection as well with dissociation and trauma. There is that diagnosis that Basudeo raised of so-called hysterical psychosis, which in the DSM-5 and TR-5 and so on process was called dissociative psychosis. And it's one that was proposed, in fact, as included as an example of other specified psychotic disorder, and was considered not yet ready by the Board of Trustees. It went all the way to the Board of Trustees. And it's a matter of documentation more than people are unfamiliar, and many of the experts. And the folks on the board are maybe unfamiliar with this cross, but it's a very interesting and difficult thing to tease apart, because trauma provokes both of them, and at extremes, dissociation can become psychotic-like. You can lose yourself in an experience, And even if you look at it in terms of psychological dimensions, psychoticism and dissociativity come together in some ways at its extreme ends. So it's very much a field in flux, and there's strong evidence for the relationship to both. And the question is, how do you decide in the case of a given person where along that continuum they may fall? And even more importantly, how much of a difference does that make? How exactly knowing how to label a person, how much does that change the treatment? And those kinds of questions, I think, are very interesting, very up for discussion, and especially when, as the panelists and the participants in general are raising, how to put all that sort of professional language jargon into the lived experience of an individual. How do you reach out to that person, encounter that person? Do the labels get in the way? How much do they help, and how much do they hinder the process of treating?
And find the context between all these together.
Yes. So
there is one more thing, Roberta, I think we have to not to forget in cultural way that the religious dissociation in some culture has a lot of things which is very, very difficult to mention, is that dissociation or is psychosis, because some of this could make as well as a part of the trauma when it's added to the religion interpretation.
Yeah.
It could be traumatic, but it also could be a way to create a meaningful context. I've assisted both in Haiti and in Brazil. And the religions of the Americas brought through the African diaspora are very similar. They even use the same terms. So what's considered psychotic in one context is a religious experience of trance and possession in a positive sense in other contexts. And no well-trained psychiatrist or mental health professional should confuse them anymore. So that's important. I want to add one last thing. This question about a spectrum and sorting out trauma and severe stress from dissociation and psychosis is particularly delicate and complex for children and youth, because you've got a moving target. And so for very good reasons, as a child psychiatrist, like with my feet firmly planted in the academic mainstream, I'm very loath to call any child psychotic. I simply say, well, they have difficult experiences and so on, because it's a moving target. And you don't know if trauma or attachment or psychosis or dissociation and a number of other possibilities, even severe ADHD, are the best explanation. So especially with children, and maybe all the time, it's just better to wait and not be so sure of our diagnosis.
Yes, there is a interesting comment from Townsend. Michelle, please.
Okay. I operate out of New York City. I'm a licensed clinical social worker, and I'm assisting individuals for the last 2.5 decades in terms of psychoses. So primarily schizophrenia, schizoaffective disorder. As New York is an international city, we do experience many different cultures, belief systems, et cetera. And it is complicated greatly. I know when Dr. Nicola had mentioned before in regards to the viewing of psychosis could be viewed in the lens or a spectrum of being positive versus negative. And we've had multiple families who may come from the Caribbean or different parts of South America that they're not akin to using traditional psychopharmacology, but they may want to go to the Botanica. Or they may think that someone with their hearing voices, they're hearing the voices of God and they're a shaman, they're connected. Or you have the more rigid kind of European model in regards to possession and being part of the devil, et cetera. Sometimes it's the same experience. It's the viewpoint of the culture that the family came from and how they process it. So that's a huge complication when we're trying to assist the individual in becoming more functional in the community. But if they go back to the family, they may take them off the medications and light a candle for them or bring them to the church, et cetera. So that's kind of the idea of culture and family and psychoses. There's so many variables that Dr. Nicola had mentioned in regards to the overlap. So I just wanted to bring that to everyone's attention.
Thank you.
Thank you very much. Thank you very much. Very, very, very interesting comment. Dr. Hazel, do you want to comment something? Because I see your name. No?
No, I didn't. You may have felt me thinking very hard, but I didn't.
That's a very good idea. That's good.
So, it turns out, Hazel, that your question is, I think, right at the heart of the matter and situates us clinically in a very, very important area. And we don't have to say, the obvious, that it's such a delicate issue today, and correctly constructing it is so difficult. Let me comment while we wait for another comment that when I was in London, the question that you raised of people from the Caribbean being overdiagnosed with schizophrenia has been studied. So Robin Murray.
Oh, has it really? Can you give me some references?
Oh, absolutely, absolutely. So let me tell you an anecdote. Robin Murray was only a little bit older than me. He would be in his early 70s. He was one of my professors when I was in psychology in London, and he's had a distinguished career as a researcher in schizophrenia. And he came to give us a talk, about 8 years ago here in Quebec, in which he said this question of, notably people from the Caribbean, from the African diaspora coming to London and Africa and other parts of the world, but notably Africa and the Caribbean. There was always a complaint, an observation among clinicians, and a complaint by the communities that if it's a Black man from the Caribbean, the person is more likely to be called schizophrenic, whereas if it's a person native to Britain, from the settlers from centuries ago, millennia ago, they're more likely to be called bipolar or something like that. Well, that has been studied, including by Black psychiatrists from the Caribbean who trained in England and did the research.
Yeah.
That has I'm not denying racism or prejudice. The British call it racialism, and so on. But there is heightened amount of psychoses and difficult experiences in immigrants. And I'm as a child psychiatrist.
Yes.
Of that. And that is not a prejudice. That is a sensitivity towards the fact that migration brings with it tremendous stress. I'm a migrant. Riyadh's a migrant. I think everybody here, maybe not Hans, but Roberto, Riyadh, and I are all migrants. And in my case, and many times I've lived in about 6 countries. But those are choices that are made, for professional reasons or when you have the means. But when you're an economic migrant, when you're a refugee, when you've been traumatized, that's a whole other story. And
exactly.
So it's not enough to say race. It's too simplistic and blinding a factor. I think it's better to say, under what circumstances are these people being diagnosed this way? Is it a prejudice? Is it a mislabel? Or is it, in fact, a way to recognize the pain and suffering they're gone through? Our friend who's now deceased, Fred Hickling from Jamaica, is a brilliant, if controversial or rather provocative psychiatrist who talks about, post-slavery stress disorder. In other words, the accumulated stressors of even in a country like Jamaica that's declared its independence, its own, or Haiti, one of the first independent, African diaspora groups in the world to declare its independence. There's still a heritage of suffering, of difficulty. And that can't be discounted. So calling it simply racism to call them psychotic can be a mistake, because it can be saying we don't recognize that there's heightened vulnerability to those kinds of ways of expressing suffering. Now, the cultural construction, the family resources around that add layers, as Michael Townsend would say. But let's not throw the baby out with the bathwater. If you are a migrant, not under the conditions that a little Vincenzo coming from Italy to Canada as an economic or family migrant, that's one story. But if you're coming from the Ukraine, or you're a child soldier from the Congo, or you grew up in miserable conditions in Pétionville or wherever in Haiti, that's a whole other story. So we need nuances above all, and we cannot forget that the intersection of trauma, including incest, as you raised, and dissociation and other severe pathology, however we call it, is a very serious question. And to simply say, well, it's just a prejudice, doesn't cut it. I think we need to respect not only the resources that people have, but also their suffering. And that's my biggest fear as a child psychiatrist, that we don't acknowledge people's suffering.
Vincenzo, thank you very much for your comment. No, I don't have any questions more here. I don't know if the audience would like to raise up the hand or not, something, but I would like to ask you, Vincenzo, and the audience about our dilemma here in Sweden, that we are working in a very individualistic social organization of society. It is very, very specific in Scandinavian, in Sweden and other Scandinavian countries. But we deal with patient who coming from a background with holistic or group organization of society, and the family involvement for the treatment is, they find it is an obligation. And when they have a member of the family who is psychosis, in this case, I find it here that we have a clash sometimes between the system we are working with individual helping the person, and to involve the family who find themselves as an obligation to be involved for the treatment. This question, I think, is still need a discussion now in organization way, because we find it here in Scandinavia still some conflict of interest between what the family find themselves in these cases and how the system look to the family.
Before Roberto says that somebody, Rembrandt Arts, has a question.
I don't have it here in question and answer.
Is that person present? Would they want to speak?
Please, Marie would like to comment.
Okay.
Hello. Yes, a person signed on under the name of Rembrandt Arts. Does that person have a question?
No, he doesn't have a question.
No, I don't have the question here.
I understand it's not in the Q&A, but the person signed up some time ago and as if to speak, but then has not spoken. But so if there isn't a comment, then we'll move to the next person.
Yeah. He doesn't have a question. Yeah.
Vincenzo, do you have any comment about what I mentioned for the clash of interest between what the family find themselves when they are coming from a background, as we working with the people from Middle East here with psychosis, and the family role where they and in the system who treat the person with autonomy and with individualistic way.
Right. Yes, thank you very much. But first of all, if you're not speaking, please mute yourself as we're hearing some background stuff. Let me say that what Riyadh is asking brings us to the heart of the question we wanted to put in this town hall meeting. I mean, having discussed a lot of the variables, you know, let's be sensitive to the family, let's be sensitive to the culture. What is psychosis? When should we call it this kind of experience? The question is, how do we answer the family's culture?
Yes.
Each family is a culture of its own, but it's also fed by the larger culture of origin and the culture that they're adapting to. So that's the heart of the matter. So, you know, you're a family from the Middle East or anywhere, Southern Italy, and you're living in Sweden, you have certain attitudes about the nature of mental distress or family experiences. And how does that impinge on your capacity to understand that your family member that's suffering, or the interactions that you have? How do you understand what the mental health professional is trying to tell you?
How to understand the symptoms.
So let me introduce an idea that I've been playing with for like 40 years. So I think a lot of cultural psychiatry and cultural anthropology is very, very important. But I think of it as like journalism or history. It's a humanity that's absolutely necessary to help us understand. I call it cultural translation. So, journalists, cultural anthropologists, a lot of these people are very, very adept and very sensitive to things. I'm very impressed when I'm interviewed by journalists at how succinct and how direct they are. Maybe there would be better interviewers than we are in the mental health professions. However, I think that's only half the work, and that's just as a metaphor, maybe 30% or maybe 90% of the work. But the other part of the work is therapeutic translation. Cultural translation is the effort to get it right. You said this, when you use the word depression, what does that mean? When you use the word hot and cold in Asian cultures, what does that mean? When you use the word possessed, what does that mean? So you listen, I call that cultural translation.
Different metaphors.
The other half of the task is because I'm not a journalist, I'm not an anthropologist. People come to me, to my clinic, with pain, with suffering, and they're looking for solutions. The other half, even if I get it wrong, is therapeutic translation. So what I do a lot of is, you just said this. Did I get that right? No, you misunderstood. Okay, let's start again. And I'll do that over and over again. So when I do family therapy workshops, I did one in Brazil recently, and the person said, it's so boring watching you because you're just asking questions. And I said, that's the point. It's not to do a show, it's to get it right. So the first part is getting it right in the most informed way possible. And if I don't have the skills, you have cultural mediators and brokers and so on and so on.
But we have a problem here that involving the family in the treatment, it is in direct, not accepted by the law sometimes here in Scandinavian countries, and that puts a lot of problems when we would like to involve the family in some cases, in some way in the treatment, but we find it that there is many restrictions in the system and in the law. And that's from the individual's point of view.
I hear you, but you know what drives me crazy as a family therapist? And I've been a family therapist and a child psychiatrist in parallel all my career, like 35 years and more. Is psychologists say to me, on my own team would say to me, oh yeah, but it's confidential. And then the parents complain, well, I have a 9-year-old daughter that was sexually abused with a male therapist, and they won't tell me what's going on in there. And I understand their concerns. So I negotiate and I said, look, I understand it's a therapeutic space and it's privileged, but we can do a meeting every 3 months or every 6 weeks to give the parents an idea where we're going so that they don't feel like they're just abandoning the kid to the winds of fate. And I completely am sensitive to that. So laws, so there's also therapeutic cultures, but let me get back to my main point. The therapeutic translation, the therapeutic culture means when you say possession, here's what I hear as possibilities. I'm very respectful of voodoo or your worldview or, jinn in, Muslim cultures.
But I will treat by my way.
But when I hear that as a physician, as a psychiatrist, I'm wondering if it isn't a response to stress. So even when it's not true, even if a kid makes something up, my answer is, why would a kid make that up? Well, we talked about factitious disorders, but why would someone make up something that didn't happen? Even if we can establish the so-called truth, why would a child be so disturbed, or anyone, that that's their way of presenting themselves? That is, I think, the challenge, both culturally and therapeutically. But we have to translate all of this sensitive, caring, and wish to get it right into a plan that is sanctioned culturally acceptable. But one of the things that drives me crazy about cultural psychiatry and cultural anthropology is we can't just take it for granted. It's my job also to try to convince people, based on the knowledge we have, even though your worldview says don't use medications, a medication might make a difference. I mean, we have a moral, a legal, and a professional obligation to tell people what the options are, and then treat them as partners in the care.
Of course.
But just to say that's the way it is and nothing else is possible is to abandon our therapeutic or our professional obligations. So again, my answer is always negotiate, talk, because, if we go by our cultures of origin, my grandmother believed in witchcraft and that kind of stuff. She wasn't crazy. She's a very intelligent woman, but I've moved a little bit beyond witchcraft, coming from a small town in Abruzzo in Italy. I've added other things, and I grant everybody I see the same privilege and the same possibility that they will learn in their new world, including from me, from other professionals, that there might be other ways to look at things.
I think you have very, very interesting when you said that we have to inform the family about the options, about the treatment, and how what we can see the role in a part of the treatment, and why we're doing what we're doing, and how we're putting our diagnosis. I think this is very important things. Is that anybody in the audience would like to share your thoughts, your ideas about the subject or the questions we're raising up? Very interesting discussions, I find it on your.
We have a few people with their hands up: Michael Townsend and Michelle Garcia.
Okay. In regards to kind of weaving together two of the different points that were brought up, one in regards to individuals' nature of the client that we serve, but living with the family and the community, and how do you be able to connect those things? Within the United States, we do have a lot of legal options in regards to HIPAA and protection and privacy, where you may not be able to talk to the family and draw them in as a resource or as a support, particularly when you're dealing with adults who are psychotic or maybe paranoid and may have transference against the family, et cetera. So it complicates that dramatically. So I agree with you, Dr. Aldwani. In regards to the other thing that weaves through every single aspect is stigma. It's pernicious, and it goes through what we see, what we hear. And
Exactly.
Dr. Nicola, as much as like when you commented about leaving Abruzzi and having the witchcraft belief, a lot of people are so afraid of losing their culture, assimilation, acculturation, not being connected to where they came from. So they hold on to potentially antiquated ideas in an effort to try to have a history, to have a sense of who they are. They don't want to lose that. So it's a complicated aspect. But in regards to stigma, the idea of not embracing what the diagnosis is, what it means for you, et cetera, it's horrendous in regards to how they're portrayed in the media, newspapers, et cetera.
I think that's such a lovely point. Let me give you a very quick answer that would be worth talking about a whole webinar or a whole Congress. I see myself as a model for the people I work with. Sometimes a negative model. I don't say, like, don't make the mistakes I made. But since I'm an immigrant and I work with immigrants, I offer myself as a model in a humble way. Like I tell coping stories, not mastery stories. So again, my point is, if I've learned, if I can adapt, so can other people. That's my positive message to people. But I also believe that I am first and last an Italian. There's 1,000 other things in there, Jewish, Mediterranean, but first and last I'm an Italian. I think I am as Italian as the president of the Republic. But what I've done is I've kept the core of what matters to me in being Italian, and also true to my best knowledge of Italy. And I consult and I work in Italy regularly. And I think that people can do that too. I mean, I don't like this subtext in our work that people are imprisoned by their origins, whether they're Haitians, whether they're my grandmother was an uneducated peasant and my mother has a grade 3 education. And I consider them brilliant women who are my models and my moral heroes. I really refuse to have these prejudices. Everybody can learn and everybody can retain from their culture the very best to guide them in life. And not only do they imprison themselves by stigma and so on, but I think sometimes we imprison them as if to say, well, that is their starting point. And they can't.
I think we have to learn from the families as well. Not just only they learn from us as a psychiatrist, we have to learn from the family as well, their way of thinking and how they share the problems. We have a comment which is very interesting from my colleagues. Wint, please, if you wanted to share your things, I would be very grateful.
Yes, thank you very much. This is a wonderful discussion and some very provocative comments that have come out. And I'm in Montreal, and I'm currently actually working with as a stakeholder with Dr. Eric Jarvis from the Montreal Jewish Hospital on trying to get community involvement in families with youths with first episode psychosis. And we're struggling with many of the issues that has come up. And so we see, there's a desire and a hope, this shift to community. But at the same time, I'm in private practice, but I also intervene very often in community settings. And I know for a fact that these community organizations are not adequately equipped. And from the family's perspective, sometimes the community themselves can be part of the problem. Particularly when it comes to stigma, or they just don't have the resources. And so, it's a wonderful idea, and I think communities should be involved. But I think we and I find this very interesting how when you first presented in the first part, Dr. Nicola, that so much came from sociology, so much came from anthropology, and the notion that this diagnosis, for example, that the medical system may be comfortable with their diagnosis, but it's the client very often that is left having to live up to often to this diagnosis, which creates in itself another problem. So I think that there's maybe some more research and some work to be done around that. And maybe then the community would be better equipped to manage, and then there'll be more of a partnership rather than, let's say, having this medical model versus traditional model. So there's a lot that came out today, and I thank you so much for this, and many blessings and continuation. Thank you.
Thank you, colleagues. Actually, I find it there is a lot of research you're doing in Jewish hospital in Montreal. When I went in 90s in McGill social and culture program with Lawrence Kermeyer, and we visited the Jewish hospital. I find it very interesting work you're doing with the communities and involving the communities in the treatment. It was really very interesting and impressed. And I read some of very interesting publication from your experiences there.
Yes,
thank you very much.
Thank you.
Quick answer to Charlotte. A long time ago, and it's still part of the left. I mean, people in critical theory, or you call them the new left and so on. There is a critique of the professions, that professions de-skill the public. And I think this is very relevant to the work, because it's not only doctors that do this, with the so-called medical model and so on. As soon as something becomes professionalized, education, health, anything, it ends up de-skilling the population. And what you pointed to as, I don't know if you mean by the community, the community of origin, the cultural or ethnic community, or do you mean the community at large in terms of having resources? So I think part of the problem of professions is we unwittingly, I mean, that's not our intention, we unwittingly de-skill people, because you say the expert on what psychosis is me, a psychiatrist, or any mental health professional. The expert on families is a therapist, as opposed to saying, well, no, it's your experience. Let's listen to how you look at it. But even when you're very, very conscientious and you're willing to listen to people, there is an implicit gradient in which people are asking for help, or they're brought for help. And in a sense, we kind of evacuate their own resources and their own skills. And it takes a tremendous amount of work to get around that. And I think that's part of the stigma of the professions.
Absolutely.
The last thing I want to say about that is that in every country and every culture in the world that's tried to move resources from institutions like hospitals to the community, it's always a bust, because the governments don't follow through and put the money in the community where we need it.
Thank you. Vincenzo, there is some of a comment which is very interesting. I would like to invite Dr. Hazel again, because she wanted to share something with us.
Yes, thank you so much. By the way, this is a gorgeous webinar. Thank you so much for it.
Thank you.
A mom and dad who are elders in a fundamentalist Christian church bring their 12-year-old daughter to me, saying she has demonic possession. All right, how does it manifest? Well, dad says, just before her bedtime in the evenings, I lift her and carry her to her room. She's not disabled in any way. She's 12 years old, 5 feet tall. Dad carries her to bed every night to put her to sleep, and then a possession manifests. And when I ask the daughter, she describes in lovely detail how the demons take her. And what I want to do behind the parent's back is high five the child and congratulate her. Because I don't know how to find words to say it, but I'm convinced that even unconsciously, she has sought a darker God. She has called upon herself for her self-defense, a darker God, to counteract the fundamentalist Christian environment that she lives in, that allows her to be tortured on a nightly basis. And I have, since that experience, felt more and more convinced that it's not simply a slip and a slide down the slope of trauma to psychosis and dissociation into possession, but I think a sprint towards it as a very viable means of self-preservation, because when you're possessed by demonic forces, everybody pulls away and lets you be. So thanks for hearing that comment.
Thank you very much. I think Professor Roberto Lewis rising up a very interesting question on chat. I think everybody reading that, and I think this is a very important question, which I try to rise up as well, because we find it how we. Could you, Roberto, comment your question, because it is very interesting, really, and it is exactly what we would like to discuss in this subject.
Sure. I guess I'm reflecting on the fact that earlier we talked about a system that does not conceive of families as being part of treatment. And so
yes, this is what I'm rising up, yes.
Yes, and you have to negotiate with that system to include the person's and the family's own cultural expectations of care. This is in some ways the flip side, an individualistic culture that sees therapy as something individuals do.
Yes.
How do you promote, how do you work with that client if you feel that bringing in the family would be helpful? Obviously, you can't do it without the person's wanting to do that, participation in it, but how do you promote this idea? What are the limits of promoting an idea that is culturally different, or may take some working through to figure out whether you are bringing up your own ideas that aren't fitting the person, or the person would benefit from these new ideas? How do you work on that?
It is not easy, actually, but here when I just reflected from the Swedish point of view, because here we are working in Sweden in very individualistic system, and the person has to decide if we can involve the family or not. So everything is doing by what the patient would like to do. But the problem is if the patient is a psychosis and he or she don't have this possibility to choose if the family will be involved or not. Another question, how will we do, as I raised out before, when the family find that the member of the family is a member of the family, and they have to be involved in not just only in the therapy, but in the treatment as well. So the conflict is not dissolved. It has to be a part of discussion. And I would like to have a clinical symposium on this subject, because this is a lot of questions rising up.
I think Anjali has her hand up.
Yes.
Yes. Hi, thank you.
Just a minute. We have just only 4 minutes left. So maybe Anjali will be the last speaker. What do you think?
It's only to add to what you were saying, really, in a way, but it also kind of expands a little bit about sharing. It links in a little bit with both what Vincenzo was sharing about having role models. I wonder the way in which we could use technology or other ways of exposing our communities to models of other families who've successfully used accessed help, who've seen ways of seeing how family can be helpful in healing our clients. I find it's a very profound way of being able to learn from looking at others, and is both normalizing and acknowledging that we're not alone in this, and this isn't something unusual that our family members suffering. Yeah.
Thank you very much. Very, very interesting. Okay, my colleagues, what I see, we have just only 2 minutes left. a lot of question rising up. A very nice discussion we have it today in different way and in different experiences, and this is what we needed to have in this webinar, and that's why we rising up this question, me and Vincenzo. I would like to give the floor to my colleagues, Vincenzo Di Nicola, for the summarizing of this webinar. Please, Vincenzo.
Well, thank you very much. I've been following the conversation very closely, including in the chat, and I find it very engaging. I hope that everybody will see this as a way to open a dialogue. I don't think there's any certainties, but there are paths to follow that would appear more healing, more promising, more respectful, because I think we're in that kind of era. We're in an era not of a scientific certitude, but of mutual respect, including and above all for vulnerable populations. So I think that this whole conversation has been a subset of this larger question about how to listen to vulnerabilities, how to make people feel less relevant, create a space where they don't feel, as Mary Mancini said, labeled for life because of a symptom. People are not, a disease is not a symptom, a person is not a label. And I think we can never learn this lesson enough. So I really want to thank everyone for listening, for contributing. And I personally am a big fan of town halls. And I would hope that this model is appealing to people, and that in the future, we invite more town halls and discussions, even more than the classical, seminar, webinar kind of situation. Thank you so much.
And I would like to thank you all of the participants for this very interesting discussion, and hope that you will join us in the future, our webinar or symposium, and hope to meet you at our World Congress of WACP on coming September in Rotterdam in Netherlands. So thank you very much, and thank you for Vincenzo Di Nicola for a very interesting speak and comments, and thank you for Roberto and Hans for your help, always help to us for this for organization of this webinar. Thank you very much for everybody, and hope to see you again in our next programs. Thank you. Bye-bye.
I also only want to add that the webinar will be showed on the website of the WACP in a few days.
And great, thank you, Hans. And if you want to join future activities of this SIG or other SIGs, please do so. We're looking for people who want to help plan these activities and think through what we should be doing. Welcome to join us.
Thank you very much for everybody. Thank you. Bye-bye.
So the organization